The topic of this presentation is orbital infections, and we'll be discussing pre-septal and orbital cellulitis and rhino-orbital mucormycosis. Starting with pre-septal cellulitis, it is an infection of subcutaneous tissue of anterior to orbital septum. It is considerably more common than orbital cellulitis, and though regarded as less serious, can still be associated with severe complications such as abscess formation, meningitis, and cavernous sinus thrombosis. Rapid progression to orbital cellulitis may occasionally occur. Organisms typically responsible are Staphylococcus aureus and Streptococcus pyogenes, with causes including skin trauma such as laceration or insect bites, spread from focal, ocular, or periocular infections such as an acute hordeolum, dacrocystitis, conjunctivitis, or sinusitis, and hematogenous spread from remote infections such as upper respiratory tract or middle ear. Uh, Diagnosis depends on signs and symptoms. The condition manifests with a swollen, often firm, tender red eyelid that may be very severe. However, in contrast to orbital cellulitis, proptosis and chemosis are absent, and visual acuity, pupillary reactions, and ocular motility are unimpaired. The patient is often pyrexial. The clinical picture is very much uh, similar to this. As you can see, upper lid is swollen, and there is some kind of trauma on the upper lid. And imaging with MRI or CT is usually not indicated unless orbital cellulitis or a lid abscess is suspected, or if there is a failure to therapy. Uh, Here, axial CT shows opacification anterior to the orbital septum. You can see it here quite clearly. Treatment is with oral antibiotics such as coamoxiclav, 250 to 500 milligram per 125 milligram 2 to 3 times daily, or 875 to 125 milligram twice daily, depending on severity. Severe infections may require intravenous antibiotics. The patient's tetanus status should be ascertained in cases following trauma. The next more important one is the bacterial orbital cellulitis. Uh, it is a serious infection of soft tissues behind the orbital septum, which can be sight-threatening and life-threatening. It can occur at any age, but is more common in children. Streptococcus pneumoniae, Staphylococcus aureus, Streptococcus pyogenes, and Haemophilus influenzae are common causative organisms, with infection originating typically from the paranasal, especially ethmoidal sinuses. Infection can also spread from pre-septal cellulitis, dacrocystitis, midfacial skin or dental infection, and can follow trauma, including any form of ocular surgery. Blood-borne spread from infection elsewhere in the body may occur. Clinical features include symptoms and signs. Symptoms consist of rapid onset of pain exacerbated by eye movement, swelling of the eye, malaise, and frequently visual impairment and double vision. There is commonly a recent history of nasal and sinuses or respiratory symptoms. Signs include pyrexia, which is often marked. Visual acuity may be reduced and color vision may be impaired, raising the possibility of optic nerve compression. The presence of a relative afferent pupillary defect in a previously normal eye makes this almost certain. Tender, firm erythematous and warm eyelids with periocular and conjunctival chemosis or edema, conjunctival injection, and sometimes conjunctival subconjunctival hemorrhage. The signs are usually unilateral, though edema may spread to contralateral eyelids. Proptosis is common in established infection but is often obscured by lid swelling. It may be non-axial dystopia, particularly if an abscess is present. Painful ophthalmoplegia, as it is shown in the picture here. Uh, Choroidal folds and optic disc swelling may be present on the fundus examination. Uh, Now, this has a huge differential diagnosis, and it can also be seen in the book as well. But just read it out. In the infection cases, it can be fungal orbital infection, dacrocystitis, or obstructive dechoroidinitis, a vascular lesion, acute orbital hemorrhage, cavernous sinus thrombosis, or carotid cavernous fistula. In neoplastic lesions, it can be rapidly progressive retinoblastoma, rectal lacrimal gland tumor, other neoplastic lesions such as metastatic lesion with inflammation, lymphoma, Waldenstone macroglobulinemia, rhabdomyosarcoma, leukemia, lymphangioma, neuroblastoma in children, or endocrine lesions like thyroid eye disease of rapid onset. Then non-neoplastic inflammatory lesions include idiopathic orbital inflammatory disease, Tolosa-Hunt syndrome, orbital myositis, acute allergic conjunctivitis with lid swelling, herpes zoster ophthalmicus, herpes simplex, skin rash, sarcoidosis, vasculitides, granulomatous with polyangiitis or Wegener's, polyarthritis nodosa, scleritis including posterior scleritis, and ruptured dermoid cyst. Now, complications include ocular complications with optic neuropathy, exposure keratopathy, raised intraocular pressure, endophthalmitis, and occlusion of the central retinal artery or vein, subperiosteal abscess, which is most frequently located along the medial orbital wall, intracranial complications, which are uncommon and usually occur in 3 to 4%, but extremely serious include meningitis, brain abscess, and cavernous sinus thrombosis. Investigations include ascertainment of a tetanus immunization status in cases of trauma, white cell count, blood cultures, cultures of nasal discharge, high resolution CT of orbit, sinuses, and brain. It's vital to confirm the diagnosis and exclude a subperiosteal or intracranial abscess. MRI is also sometimes performed, lumbar puncture if meningeal or cerebral signs develop. Then coming to treatment, first of all, hospital admission is mandatory with urgent otolaryngological assessment and frequent ophthalmic review. Pediatric specialist advice should be sought in the management of a child, and a low threshold should be adapted for infectious disease specialist consultation. Delineation of the extent of erythema on skin using a surgical marker may help in judging progress. Antibiotics are given intravenously with a specific drug depending on local sensitivities. Ceftazidime is a typical choice, supplemented by oral metronidazole to cover anaerobic pathogens. Intravenous antibiotics should not be continued until the patient has been apyrexial for 4 days, followed by 1 to 3 weeks of oral treatment. Monitoring of optic nerve function is performed at least every 4 hours, initially by testing visual acuity, color vision, light brightness appreciation, and pupillary reactions. Deterioration should be prompt, and in that case, surgical intervention should be considered. Surgery includes drainage of an orbital abscess. At an early stage, drainage of infected sinuses should be considered if there is a lack of response to antibiotics or if there is a very severe sinus disease. Biopsy of inflammatory tissue may be performed for an atypical clinical picture. Severe optic nerve compression may warrant an emergency canthotomy or cantholysis. Next infection is Rhino-orbital mucormycosis. Mucormycosis is a rare, aggressive, and often fatal infection caused by fungi of the family Mucormycosis. It typically affects patients with diabetic ketoacidosis or immunosuppression and is extremely rare in the immunocompetent. Infection is acquired by the inhalation of spores, which give rise to an upper respiratory tract infection. Spread then occurs to the contiguous sinuses and subsequently to the orbit and brain. Invasions of blood vessels by the hyphae results in occlusive vasculitis with infarction of the orbital tissues. Diagnosis includes symptoms and signs. Symptoms include gradual onset of facial and periorbital swelling, diplopia, and visual loss. Signs are similar to bacterial orbital cellulitis but tend to be less acute with slower progression. Infarction superimposed on septic necrosis is responsible for classic black eschar that may develop on the palate, turbinates, nasal septum, skin, and eyelids. Complications include retinal vascular occlusion, multiple cranial nerve palsies, and cerebrovascular occlusion. We have already discussed the differential diagnosis. Investigation is much the same as for bacterial orbital cellulitis. Now, coming towards treatment, correction of the underlying metabolic defect should be instituted if possible. Intravenous antifungal treatment is given. Daily packing and irrigation of the involved area with antifungal agents. Wide excision of devitalized and necrotic tissue. Exenteration may be required if unresponsive cases in order to reduce the risk of death. Adjunctive hyperbaric oxygen may be helpful. So this is it with the orbital infection. If you like the lecture, please press on the like button and subscribe to the channel. Thank you.